Can I go ahead and start? Hello, good evening, everybody. I am Dr. Lorianne Fisher, and I am a nephrologist at the University Hospital of the West Indies, and I'm really happy to introduce everyone tonight to hopefully the first of a series of lectures on a nephrology lecture series geared towards the people who are really important in managing people with kidney disease, and that's our primary care providers. I'm hoping tonight is an exciting night. I hope it begins a partnership with the International Society of Nephrologists, specifically our North America and Caribbean Regional Board, with the Caribbean College of Family Physicians. We hope that today's talk, which is kind of the evaluation of patients with an elevated creatinine, starts off a series of lectures on the approach on managing kidney patients amongst persons with family physicians. I'd like to think of our family physicians or primary care doctors as the eyes and ears of the nephrology community. You guys are the ones that pick up the diseases, and you are so crucial in managing kidney disease. And I'm hoping that you guys learn and we learn from each other. And I'm extremely happy to start off and pleasure to introduce our speaker today. Professor Edgar Lerma is well known in the nephrology community. He is a professor of medicine, a nephrologist at the University of Illinois in Chicago. Just some background, he earned his Doctor of Medicine degree from the Philippines, the University of Santo Tomas Faculty of Medicine and Surgery. He completed residency training in internal medicine at Mercy Hospital and Mercy Medical Center, where he served as a chief resident. He headed to he did his fellowship at Northwestern Memorial Hospital, at Northwestern University. And after finishing his fellowship, he's kind of had this great career in academic medicine, and specifically teaching. He's authored over 100 peer-reviewed publications, and he's a clinical professor at the section of nephrology at University of Illinois at Chicago. Anyone who is on Med Twitter knows that Professor Lerma. He is a big educator with a big social media presence. I've learned so much from his tweets, and I'm sure you guys will learn so much today. In addition to a number of lying on a number of editorial boards, he is a fellow of the American College of Physicians, a fellow of the American Society of Nephrologists, and American Heart Association. And he's won numerous awards in teaching, subspecialty teaching, attending physician of year in 2006 and 2011, and just an excellent overall patient advocate. His interests include CKD, hypertension, and bone mineral disorders. And without further ado, I kind of welcome a great talk today by Professor Lerma.
Thank you so much for that wonderful introduction, Lori. Let me try to see if I can share my slides here. Just bear with me. Okay, I hope everybody can see my slides. Again, this is our hopefully inaugural lecture series in nephrology. And, as Lori pointed out earlier, I do believe that our primary care providers are the first line of defense, so to speak. We would like to always collaborate with our primary care providers because you are the ones who see these patients early on before most of us nephrologists do. Without further ado, my topic is again approach to the patient with an elevated serum creatinine. So when you see this patient, whether in the inpatient setting or in the outpatient setting, and you see this patient with an elevated serum creatinine, what do you have to think about, and how do you go through the process? So here I just want to briefly show my disclosures. So when we see an acute elevation in serum creatinine, we have to understand that not all serum creatinine elevations mean kidney dysfunction. Although, the common thinking here is that you see somebody with elevated creatinine, you already think about, okay, there's kidney disease, kidney dysfunction. In actuality, there are so many situations wherein the creatinine may be elevated, and yet they don't necessarily mean kidney dysfunction. And I'll just go through some of the examples here. And I promise you, this is the only physiology slide that I will be showing. When we talk about creatinine, we have to remember that creatinine is actually a waste product of creatine metabolism, right? So a small amount is actually derived from the dietary sources like cooked meat principally. So creatine rather, is synthesized in the kidneys, the liver, and the pancreas by two enzymatically mediated reactions, including here you could see glycosamine and arginine. And this is then transported in the blood to the muscle where it is phosphorylated to what we call now phosphocreatinine. The phosphate here being donated by ATP, which you remember from physiology and biochemistry is your adenosine triphosphate. And then the interconversion of phosphocreatine and creatine and concomitant interconversion of ADP and ATP. This provides the energy source for our muscle contraction. Now, daily, around 1 to 2% of creatine is actually in our muscles. And this is converted to the waste product, creatinine, which is now our topic. Creatinine is then released from the muscle cells to the circulation. The amount of creatinine produced depends on the total muscle mass, and therefore it varies considerably between individuals. So it's usually in the order of, let's say in children, around 0.5 grams per day. In adult females, maybe around 1.5 grams per day. And of course, in adult males, 2.0 grams per day. Now, we have to recognize that there is variability between individuals. For a given individual, the daily creatinine production remains pretty well constant as long as the total muscle mass is unchanged. So finally, creatinine is cleared from the body by the kidneys, and this is principally during glomerular filtration. So a small portion, or maybe around 7 to 10%, is actually cleared by tubular secretion. And that's why we use creatinine as a sort of biomarker for kidney dysfunction. So when we see creatinine, we have to remember that there are factors that can elevate your creatinine acutely or even chronically. And we have to consider this because, as I said earlier, the main premise I'm saying here is that not all creatinine elevations make you think kidney dysfunction. So, for instance, we will look at this as an acute rise in creatinine, a false elevation in creatinine, and of course, an acute fall or blunted rise in creatinine. So, first, any person who eats a heavy diet or heavy meat consisting diet, so red meat a lot, that is an intake of creatine that's high that can cause an acute rise in creatinine. So this is similar to some patients who actually take protein supplements, right? Like creatine powder. So sometimes you can see that elevation in serum creatinine. But again, just as a warning, again, this may not necessarily mean that the patient has kidney dysfunction, right? Another thing that can cause increased creatinine generation is a condition called rhabdomyolysis, which we call acute myoglobinuric failure when it goes into AKI. So we know that, as we said earlier, creatine is metabolized in the muscle, right? And when there is damage to the muscle, whether it is traumatic or non-traumatic, this can cause an elevation in your serum creatinine along with your creatinine phosphokinase or CPK. There's also a condition called decreased glomerular filtration, which is what we are going to talk about most in this discussion, which is when the patient has an acute kidney injury. And of course, there's the concept of reduced tubular secretion of creatinine. Remember, I said a small amount, 7 to 10% of creatinine is actually secreted in the tubules. Now, there are a couple of medications which are commonly used, you know, maybe for urinary tract infection, for peptic ulcer disease, for dyspepsia. So these two medications actually inhibit the tubular secretion of creatinine. Hence, some patients may have an elevated creatinine just because they are taking these medications. I remember, and I'm going to date myself, and Lori mentioned I did my training at Northwestern many years ago, I'd say eons ago. So I remember at that time we would have some patients come to the clinic with an elevated serum creatinine. And at that time, that was the era wherein the proton pump inhibitors were new. At that time, I think only omeprazole was the proton pump inhibitor available, but most patients with peptic ulcer disease took mega doses of cimetidine round the clock. And because of that, they would come into the clinic because of elevated serum creatinine. And the only solution is to just either discontinue the cimetidine or cut down the dose, and the creatinine would nicely decrease. So there are also false elevations in creatinine. And here, you know, you have to go back to your biochemistry and your physiology, maybe organic chemistry, wherein we know that there are some substances like glucose, maybe hemolysis, a high protein level, even lidocaine can interfere with the reaction that is used in the lab to measure serum creatinine. So this can also cause false elevations of creatinine. And of course, there are patients in whom, you know, you see the creatinine, they're not elevated, maybe because they're septic. Meaning to say, if they were well, their creatinines would probably be even higher. So again, this is like an acute fall or blunted rise in creatinine. Patients with increased volume of distribution, like patients with edema or patients with fluid overload. Now, let's go to the flip side. How about effects on chronic effect on creatinine? So these are things that affect baseline GFR and the ability to generate creatinine rise during AKI. So the list here actually parallels the one on the left side. So what would cause a chronic elevation in creatinine? Remember, we said earlier, heavy meal, which is consists of a lot of meat or beef or, you know, red meat in particular. Well, we can also look at increased creatinine generation. And this you can see in patients with muscular body habitus. It has been shown in studies that patients of Afro-Caribbean ethnicity have a particularly high creatinine as compared to a Caucasian population. Of course, decreased GFR, like in chronic kidney disease, can cause a chronic elevation in creatinine. And of course, again, we mentioned about the lab interference, right? So bilirubin hemolysis can cause interference with the laboratory tests used to determine serum creatinine. How about a chronic decrease in creatinine? So when do we see these patients who actually have low creatinine? Probably those patients who are vegans, they only eat um, less meat. They can have low creatinine values as well. Patients with lower muscle mass. So let's say patients who are amputees, patients who are elderly, the female gender as compared to the male gender have lesser creatinine values as well. Of course, patients who are cachectic, malnourished, and have critical illness. If you want to read more about this topic, this is the reference, the definition of AKI and its use in practice. Now, this slide, this is from the latest publication of the KDIGO, which is the latest clinical practice guidelines on the management of chronic kidney disease. And here, they actually devote a table to the reactions that I mentioned earlier, right? So we were talking about the Jaffe reaction and also enzymatic interference. And you could see here the different medications or drugs that we sometimes use. So what I'm trying to say is that whenever we see an elevated serum creatinine, we first have to verify, is this value true? One. And second, does this imply kidney dysfunction? So let's say we have passed that. Now we are at the point wherein, okay, we know that this patient's creatinine is true elevation. It is not just muscle mass or anything. It is not because of a medication or a reaction in the lab. So the question is this an acute or chronic elevation of creatinine? And it turns out this is a nuanced question. So if you look at the left side, there are many ways. How do you know that a patient has an acute or chronic elevation in creatinine? Where do you base it? Is it the creatinine based on the last 7 days from the time of, or is it the creatinine at the time of admission? Is it the creatinine from 1 year ago? Where do you draw the line? And as you can see, if you look at all of these measures, really, there are a lot of limitations to using these definitions to differentiate acute versus chronic. So in reality, you might say, well, I don't know, right? So what do I do in practice? Well, what I do in practice is when the patient comes in, I usually look at the labs from the previous days to years, if that is available. That helps, at least I know where they start and where I could, when the creatinine goes down, at least where can I expect them to be at what sort of range. However, how about that patient wherein they absolutely come to you for the very first time, nothing else, and they have an elevated creatinine? You don't know how long it has been that way. You don't know if this just happened yesterday. You don't know if this has been like that for 5 years, right? So in those situations, that's when you start having to work this up. In my practice, what I do is I'd say elevation in creatinine, question mark, acute versus chronic. And then I would order my lab tests. And those lab tests, imaging studies, will help guide me in saying, okay, this is an acute elevation, or this has been a chronic elevation. That's why sometimes it's really helpful if you have the past laboratory studies. Now, when we see patients with elevated creatinine and we say, okay, this is acute kidney injury, we have always been taught in internal medicine that the first approach to this is you determine, is this pre-renal, is this post-renal, or is this renal, right? I like to go pre-renal, post-renal, renal, simply because post-renal is so easy to eliminate right away, right? If you eliminate that there's an obstruction or there's no obstruction, then off you go. That's not part of the differentials anymore. When you see a patient with AKI, elevated creatinine, that is true, you have to consider the risk factors, age. So we know elderly patients are mostly at risk for AKI. Patients who are male have higher risk for AKI. Patients with underlying chronic kidney disease, meaning to say they have chronic kidney disease for a long while and now they have an acute kidney injury on top of that. Patients with a history of diabetes, proteinuria, heart failure, even liver disease. And then there are illness-specific risk factors for AKI. So here you think about drug exposures, nephrotoxins, right? You're talking about, let's say nowadays we have a field in nephrology called onconephrology, which deals with kidney disease and malignancy. So you have to consider those medications. You have to consider those medications that are actually um, given for chemotherapy, let's say to treat cancer. Um, Also consider patients with sepsis, cardiogenic shock, hypovolemic shock, or patients we see in the ICU with multi-organ dysfunction, and also surgery. I like to mention surgery because one of the common causes of AKI is what we call cardiac surgery associated AKI. So this could be patients who undergo coronary artery bypass graft surgery. They undergo an aortic valve replacement like a TAVR. These patients are at high risk for AKI. Again, this is the inpatient setting. So let's say now I have a patient with acute kidney injury. The creatinine is elevated. What tests do I order? So here are the tests that I usually order. You have a blood count, a urine dipstick, and a urine microscopy is very important. Of course, renal ultrasonography, as we shall show later, is part of the way by which you eliminate post-renal failure, and other electrolytes, your sodium, potassium, BUN, your calcium, so on and so forth. So this is a paper that was published in actually this is a letter to the editor that was published in the New England Journal of Medicine. And basically in this study, they did urine microscopy. So I remember when we were fellows, we would have slides and cover slips in our pockets, and we'd run around seeing consults. And again, this is a process wherein you collect the urine of a patient. You're being consulted for AKI, and then you centrifuge them, you put them on a slide, cover slip, you stain them, so on and so forth. So these are nice pictures actually. And you could actually, if you have a microscope, you can use your iPhone to even look at the, there's an app that you can use to actually look at this. So very useful in my practice. So the practice of urine microscopy is time immemorial. So this is something that has been ongoing for many centuries, right? So I remember one of my mentors, Dr. Murray Levin, he called urine the golden elixir of life. So when we have patients who hasn't been making urine, and then patient starts to diuresis, and he would say, "So floweth the golden elixir of life." I always remember that. But anyway, so urine microscopy, you can look at the microscope, you can look at the different cells. These are very helpful. You could see here, if you see an RBC cast, this is usually the sine qua non of glomerulonephritis. If you see a WBC cast, this would imply pyelonephritis or infection. Now, there are also other lab tests that we order wherein we check the patient's urine studies. And you probably hear a lot about this. This is the fractional excretion of sodium and the fractional excretion of urea, of course, FeNA and Phe-urea, respectively. So in addition to your chemistries, which includes your BUN and your creatinine and your serum sodium, you also order a urine sodium and urine creatinine and urine urea, and then you plug it into these equations. When you see a value of FeNA of less than 1% or a Phe-urea of less than 35%, this makes you think that this patient has what we call pre-renal AKI. And we will discuss that a little bit more later. However, there are some caveats to using these formulas. So there are things that will cause a low FeNA in patients with actual renal causes of injury. Okay, so let's say a patient has cardiorenal disease. That means the heart is not pumping well, so there is decreased perfusion of the kidneys. That would be interpreted by the kidney as a low flow state. So the kidneys, reading it, will hang on to the sodium. And so your FeNA, the amount of sodium spilled in the urine, is much less. Hence, you have a FeNA of less than 1%. Now, other conditions that would cause this sort of low flow state, renal artery stenosis, right? Hepatorenal disease, we'll talk about this a little bit more later. Glomerular diseases, tubular interstitial nephritis. Look at radio contrast dyes. If you give a patient a contrast, one of the things that the contrast dye will do is it causes vasoconstriction. Hence, the kidneys read this as a low flow state. So there are limitations to the use of the FeNA. So you have to look at these conditions, right? So when you see these conditions, your FeNA may not have any value. That's why sometimes I teach my residents that when you see a FeNA, it is only valuable if it is less than 1%. Because if it is above 1%, all bets are off. It could still be pre-renal, right? Now, we can also use FeNA as a diagnostic measure for something called hepatorenal syndrome. When your FeNA is significantly low, let's say 0.5%, that speaks highly of hepatorenal syndrome. So, where does Phe-urea get in? Well, there are studies that actually show that Phe-urea may be more useful in patients who are actually on diuretics. Remember, when you give a diuretic, it causes the patient to spill sodium in the urine. And so urea is absorbed in the proximal tubule. So it is not affected by diuretics in that sense. So there are some caveats here on when you should use FeNA and when it is best to actually use Phe-urea. So let's now go back to what we were talking about earlier. So again, when you see AKI, you think pre-renal, you think post-renal, and then you think renal. So let's start off with the pre-renal, okay? So when we say pre-renal, we're looking at something that is low flow state, meaning to say there's less perfusion to the kidneys. And what would cause this? Goes back to a little bit about renal physiology, right? We remember this diagram. You have an afferent arteriole, efferent arteriole. I usually had trouble remembering this. So I remembered somebody thought about this and he said afferent is arriving, efferent is exiting. So these two arterioles would modulate whether constriction or dilation in order to maintain normal GFR. That's what they basically do. So when you have decreased perfusion pressure, whatever the cause, what happens is that the body releases prostaglandins, which would dilate your afferent arteriole. This also would lead to a constriction of the efferent arteriole caused by your angiotensin II. And what is the effect of this too? Then you have maintenance of normal GFR. So there's normal flow through the kidneys. Now, what if you have low flow state, your volume depleted, and then you take an NSAID because you're in pain? Remember, one of the responses earlier to decreased perfusion pressure is the release of vasodilatory prostaglandins. Now, those vasodilatory prostaglandins are inhibited because of the NSAID effect on your arachidonic acid pathway. This then causes low GFR. Okay, so you could see when do you see this? You see this in patients who are volume depleted and they were given NSAIDs. How about if the patient is again volume depleted and they were given an ACE inhibitor or angiotensin receptor blocker, or they were still taking it and they were volume depleted. So again, now you could see the effect is on the efferent arteriole, and you could see there's decreased angiotensin 2. So you dilate the efferent arteriole. Again, the effect, low GFR. So some of the patients that we see are having this situation, right? They're volume depleted. They were given NSAIDs and they were given an ACE or an ARB, or they're still taking these medications. And this is what we call like a perfect storm, right? So these patients have perfect storm that predisposes them to prerenal AKI. So we talked about NSAIDs, we talked about angiotensin receptor blockers, cardiorenal syndrome. You know, we know that in any state wherein the heart is unable to pump blood towards the kidneys. Let's say they have congestive heart failure, they have a heart failure, reduced ejection fraction. This will cause decreased flow to the kidneys. And this will cause an elevation in creatinine. Patient will have AKI or acute kidney injury. How about hepatorenal syndrome, right? Hepatorenal syndrome is really an imbalance of your vasoconstrictors and vasodilators. So what it is that, you know, the liver is unable to remove all of these substances. And so because of that, there is also a prerenal state. Abdominal compartment syndrome. You see this in patients who suffer from abdominal trauma. You know, I remember I had a case of a patient who had a abdominal compartment syndrome, and the residents thought that this was all pre-renal, so they kept giving the patients fluids. Okay, so they kept giving the patients fluids, but the patient was not responding. He was not making any urine. 3-4 days later, they consulted us, and we saw his muscles on his legs. They were very tight. So they had to do fasciotomies in order to release the pressure. So this is just an example of somebody having a compartment syndrome. Again, when there is pressure in the abdomen, it causes renal venous congestion, and that could also cause AKI or acute kidney injury. Other causes, you know, what are the other causes of volume depletion? It could be from diuretic overuse, you know, maybe from osmotic diuresis in patients with diabetic ketoacidosis. How about extrarenal loss? Maybe from vomiting, from diarrhea, patients who has burns, patient who has profuse sweating, or even blood loss. I want to touch base a little bit about contrast nephropathy, right? So nowadays we call this contrast-associated AKI. It's no longer contrast-induced; it's associated. Some as a nephrologist, we hear people talk about this. There are some people who believe that it exists. There are people who don't believe that it exists. But I think it is present. It's just maybe we are overdiagnosing it. So it does make sense. How does contrast cause damage to the kidneys? Well, contrast is a vasoconstrictor. So then it causes a prerenal picture, right? But secondly, contrast is also tubulotoxic. It's toxic to the tubules. So that being said, there's physiological evidence that patients who are exposed to contrast can have AKI. But there are patients who are at risk, right? Patients who are elderly, patients with chronic kidney disease, diabetes, they have more cardiac problems, so on and so forth. The thing is that there are patients in whom they may have normal creatinines. They may not have risk factors for contrast-associated AKI. So in those patients, it's okay to give them contrast. In the other patients who are at high risk, then you could give them prophylaxis. And the only prophylaxis we give for contrast-associated AKI is really fluids. So what if your AKI patient with prerenal failure now is not treated right away, or is not brought to the hospital right away? So what happens is that if you look at this picture and the diagram on the right, this is how the tubule looks like. Okay, you could see on the left side, this is the tubule on the longitudinal perspective, while if you cut them in cross section, this is how it looks like. So if you don't treat it, eventually these cells start behaving badly. And so what happens? There's loss of polarity, then there's ischemia and reperfusion injury. What happens is that these cells then become necrotic. They start to slough off. And this is what we now see as muddy brown granular cast. That's why if you look under the microscope, if you look at the textbooks, you always hear this muddy brown granular cast. Whenever you see this, you always think acute tubular necrosis. Now, the area of the tubules, which is most prone to acute tubular necrosis, is the area when there is lowest oxygen tension in the loop of Henle. And remember, that portion of the tubule is responsible for concentrating urine. Hence, when you see patients with acute tubular necrosis, that urinary concentrating ability is dysfunctional. So patients are unable to concentrate urine. Hence this mean. So I like to go from pre-renal. We talked about that. Now we go to post-renal. What are the things that can cause post-renal? Easy, obstruction, right? Whether it's extrarenal or intrarenal. You could talk about benign prostatic hypertrophy, even cancer, a neurogenic bladder, retroperitoneal fibrosis, maybe from medications or from previous surgeries, and also stones, stones like crystals. There are some medications that can cause crystals. We know that like acyclovir, indinavir, blood clots, or even tumors, as we mentioned. So this is an example of an ultrasound of the patient. The top one shows a normal sized kidney, and you could see the second one, this is a hydronephrotic kidney. Now we go to intrinsic renal failure, right? This is what we call renal failure. And if you look, when you think renal, so remember, you ruled out pre-renal, you ruled out post-renal, now you are going to think renal. So we think glomerular compartment, we think about interstitial compartment, tubular, and vascular. So a lot of this have overlap, but so this slide just basically shows you what are the possible causes. When you do your initial laboratory studies, you ruled out pre-renal, you ruled out post-renal, and now you start thinking about renal causes. So you think about this differential diagnosis, and there are certain tests that you can order that will support that diagnosis. I want to concentrate now on the glomerular diseases, right? So whenever we think glomerular diseases, we have to sort of separate them. Nephrotic syndrome, which has the elements of peripheral edema, right? Nephrotic range proteinuria, some books say greater than 3 grams per day proteinuria, some books say greater than 3.5 grams per day proteinuria. These patients also have hyperlipidemia and hypoalbuminemia. The fifth component of nephrotic syndrome nowadays is believed to be hypercoagulability, because these patients, they lose these coagulant proteins in the urine. On the flip side, there is something called the nephritic syndrome. This is the nephritis, inflammation of the glomerular. These patients are a little bit more acute in setting, meaning to say they're staring you right in the face. You have to do something right there. Nephrotic patients, they tend to be more insidious. They're a little bit slower. So these nephritic patients, they have hypertension, they have significant hematuria, they have oliguria or even oligoanuria. And of course, here you have the Burger King mascot being depicted as a sort of a parody of Berger disease, which is the most common cause of primary glomerulonephritis. So just a way of differentiating. Netter depicts this in this nice figure, and you can see the same things that I mentioned earlier. One thing we have to understand about glomerular diseases is that you cannot, while I say there's nephritic and then there's nephrotic, some of the diseases actually have both, while some diseases have more of one or more of the other. Okay, so it's important, and this is where the nephrologist gets really involved, because these are usually findings that we see on the renal biopsy. But as primary care providers, when you see a urinalysis, you see that dipstick, you see there's lots of blood, there's lots of white cells, there's lots of protein, and you're thinking this could be glomerular, you know, call your friendly nephrologist, and I'm sure they'd be happy to help and, you know, guide the treatment plan. I want to talk about something tubular interstitial now. Um, in med school, we were taught, okay, you think about tubular interstitial nephritis when there's fever, rash, and eosinophilia, right? We memorized this in med school when we were residents. We took the board exams, fever, rash, eosinophilia. It turns out that this combination of symptoms, fever, rash, eosinophilia, and signs, combination of symptoms and signs, is only seen in less than a third of patients with interstitial nephritis, but still there, you know. So when you see it, then you have it. But if you don't see it, it does not mean you don't have it. You still need to have it fit the right description, right? So one of the tests that we have been ordering for a long time, and this was again dating back to even when I was a med student, is urine eosinophils, right? Whenever we see urine eosinophils, say, oh, that's interstitial nephritis. So let's look at what the data shows. So this is a study that was published in CJSN. Moriti et al. Actually did a study, and they look at patients who had interstitial nephritis demonstrated by biopsies. And what they did was they said, well, let's look at how many of these patients actually had eosinophils. And look, sure, true enough, acute interstitial nephritis patients had significant elevation in the urine eosinophils. But look at this. Patients with proliferative glomerular nephritis also had eosinophils in the urine, even higher than AIN, right? And look at patients with acute tubular necrosis. They also had high urine eosinophils. So urine eosinophils are found in a variety of kidney diseases aside from AIN. At the commonly used 1% urine eosinophil cutoff, the test does not shift pretest probability in any direction. So even if you use a higher cutoff, 5% cutoff, the eosinophils in the urine perform poorly in distinguishing interstitial nephritis from ATN and other kidney diseases. So, you know, ever since this paper was published, I think this was back in 2013, I stopped using urine eosinophils in my practice. Now, one of the things that's also important is we said, what are the most common causes of interstitial nephritis? There are two most common causes, drugs and infection. So sometimes when I explain this to the patients, you know, you're damned if you do, you're damned if you don't. If you have an infection, the infection will hurt you. If you don't, if you treat the infection, the treatment for the infection will also hurt you, right? Damned if you do, damned if you don't. Now, if you look at the drugs that have been associated with AIN, we know the number one drugs that are used are antibiotics, right? In the past, we say, oh, beta-lactam antibiotics, infections. These are the most common causes of AIN. But look at these drugs, PPIs, right? We see a lot of PPIs being ordered. Dyspepsia, proton pump inhibitor. Peptic ulcer disease, proton pump inhibitor. GERD, proton pump inhibitor. It turns out that there's a study that actually looked at this and showed that there is a correlation between chronic kidney disease and the use of proton pump inhibitors. So the recommendation nowadays is that, you know, so as a nephrologist, when I see these patients, I would ask them if they have CKD. I'll say, are you on any proton pump inhibitor? And if they say yes, I ask them, do you know why? And I'll say majority of them don't even remember why they were started on it. Those are the patients whom there might be impetus to deprescribe the medication. On the other hand, be careful in just deprescribing, because there are patients with, say, severe GERD. They do need the proton pump inhibitor. So I know what you're asking in your head, and you're saying, why is Dr. Lerma saying, PPI is linked to CKD? What is the mechanism? Well, the mechanism, I don't know for sure. There are some case reports that say maybe proton pump inhibitors cause the interstitial nephritis, as we just showed. There are also studies in mice wherein they showed that the endothelial cell grew older faster than the normal endothelial cells in patients, in the mice that were given proton pump inhibitors. This is what we call glomerular endothelial senescence. The cells were getting older faster. So when you see a patient and then you're suspecting, okay, this is drug-induced acute interstitial nephritis, again, you monitor this, you work with your nephrologist. One of the treatments that we use for these patients is use of steroids. We try not to use steroids as much as possible. The first line of treatment really is to try to discontinue the medication that caused it. So this is just a nice algorithm I'm sharing with you now. So what happens? We see these patients in the hospital, right? They have acute kidney injury. We think some of these patients will recover, and then some of them will get into chronic kidney disease, right? But it's not as simple as that. It turns out that these patients, when they have AKI, they have several pathways. They can have recovery, which is what we want to achieve. They can have death, which what we want to avoid, right? And sometimes there is non-recovery. So those who don't recover can have delayed recovery, they can develop CKD, and then there is something wherein in between AKI and CKD called acute kidney disease. So these are the patients who, let's say, I'll give you an example. Let's say a patient has a baseline creatinine of 0.5, comes to the hospital because they have nausea, vomiting, diarrhea, and then they come in with a creatinine of 2.5. So went from 0.5 to 2.5. In the hospital, you give them fluids, you remove the nephrotoxic agents, the creatinine goes down to 2.0, right? And now the patient is discharged. What happens to those patients, right? Those patients have to be followed closely, because if they stay at 2.0, then they go into AKD, or acute kidney disease, and then chronic kidney disease. You have to monitor these patients after they are being discharged from the hospital. You want to see them get as close as possible to back to baseline if possible. So that is where you as primary care providers, us as nephrologists, work together in trying to find out what else is going on in here. So once they're discharged from the hospital, their course is not finished. So when they get into chronic kidney disease, now we talk about the stages of CKD, right? And I'm just going to briefly go through this, because I'm hoping this would be another topic for our future webinars in this series. So you notice when we talk about stages of CKD, we talk about their GFR, right? Stage 3 is 30 to 59, stage 4, 15 to 29, GFR less than 15, or dialysis stage 5. You notice I never mentioned the GFR number in AKI, right? And the reason for that is because in AKI, the patient is unstable. So their GFR could be anywhere. It is not very useful to label them as having stage 3 or stage 4 while they are in the hospital. It does not make physiologic sense. So going back to our diagram, so when you go to AKI, go to acute kidney disease, hopefully you can get them back and not get to CKD. If they do get to CKD, you have to start risk stratifying the patients. We have this table wherein patients we follow for CKD, we have to, you look at the stages and then you risk stratify them based on the degree of albuminuria. right? So nowadays, we don't use the term microalbuminuria or macroalbuminuria. Now we use A1, A2, or A3. A3 is severely increased albuminuria, greater than 300 milligrams per gram. A1 is less than 30 milligrams per gram. Now, it is important for us nephrologists to collaborate with you, our primary care providers. And when should we refer patients, right? So we talked about AKI patients, right? When you work them up, it's not pre-renal, it's not post-renal, renal, you probably have to refer to nephrologists. Sometimes if they're pre-renal and they're complicated, they have cardiorenal syndrome, hepatorenal syndrome, cardiac surgery associated AKI, the nephrologist, your friendly neighborhood nephrologist, will be very helpful. So in the CKD realm, when the cause of the CKD is uncertain, let's say the patient has no diabetes, no high blood pressure, they have persistent proteinuria and hematuria, call the nephrologist. If you see that they have hereditary kidney disease like polycystic kidney disease, autosomal dominant polycystic kidney disease is the fourth most common cause of kidney failure in the US. Patients with recurrent stones, right? And it's important for you to be able to risk stratify these patients, because there's a lot of things that we as nephrologists and you as primary care providers can collaborate on to decrease or delay dialysis, delay the need for a transplant. And of course, this entails monitoring your albuminuria, monitoring your GFR. So there are actually studies that show that early versus late referral has a lot of consequences. Some of the benefits that when we collaborate is we can delay dialysis or transplant. There may be less need for urgent dialysis, meaning to say we end up having patients, if they do require dialysis, they have a PD catheter or a fistula, as opposed to having an IJ dialysis catheter. Preemptive transplantation is golden, right? This is when patient gets transplanted with a kidney long before the patient needs dialysis. It also leads to less costs because there's decreased hospital stay. There's lower 1-year mortality rate. And of course, patients are empowered because they have the freedom of choice. If we collaborate early, we can give them the tools to, okay, home dialysis for me, or in-center dialysis is for me. So they are part of the decision. We can also improve their nutrition. And of course, there's a lot of psychosocial issues that patients have to deal with. We can easily identify that earlier and refer them to the right people. So what if we do not collaborate? Well, studies have shown there's increased morbidity and mortality. There's more complications, right? Low prevalence of permanent access, meaning to say less AV fistulas, AV grafts created. There's delayed transplantation, and so on and so forth. So in reality, there are now CKD care models. We always encourage having a multidisciplinary team approach. We have the primary care provider, nephrologist, the specialist, social worker, dietitian. Some interventions we can collaborate on: blood pressure management, right? Diabetes management, putting them on a statin, making sure anemia is addressed and worked up. The mineral bone disorder, you look at the calcium, the phosphorus, and the PTH. You educate the patients and their families about the different options, whether to go home dialysis, in-center dialysis, transplant, planning for the vascular access. And of course, outcomes: you delay progression of CKD, you improve blood pressure and diabetes control, improve cardiovascular outcomes, and also patient education. So really, these are the components of this collaborative model. We have education, navigation, management, and of course, surveillance. Again, I'd like to show this slide, which I showed earlier, right? We identify patients who are at risk for having AKI. So what if we do identify, okay, you are at risk for AKI? Well, one, You can discontinue all nephrotoxic agents when possible. If they're an NSAID, you stop them. If they're intravascularly volume depleted, you give them fluids. If you can monitor their creatinine, their urine output, other alternatives to contrast imaging studies, right? And again, this timely initiation of dialysis when needed, all of these things can be a little bit more coordinated. So the last slide I want to show is that, remember I said not all creatinine elevation is kidney dysfunction. Not all creatinine elevations are bad, right? In this slide, you could see on the bad, this is what we have been talking about. Patient has spontaneous AKI because there's cardiorenal syndrome, hepatorenal syndrome, sepsis, nephrotoxin-induced like contrast, right? These patients, you have to treat them because the creatinine rose up as a biomarker. And if you do not treat them, the outcomes will be worse. However, there is what we call induced AKI. This is some people call this as permissive hypercreatinemia. Okay, let me repeat that. You in pulmonary you hear permissive hypercapnia, right? Here this is what we call permissive hypercreatinemia. So let's say a patient is congested. You give them diuretics. You want to diurese them, right? So patient pees a lot, but you know the creatinine is going to go up. That's expected. That implies better outcome later on. In fact, there are studies, I believe it's the dose study, that showed that patients who actually diuresed or had worsening kidney function, so to speak, actually had better outcomes subsequently. Patients whom you put on a RAS inhibition, you know the creatinine is going to go up by what, 10%, right? That's what we expect. You know that if you start them on an SGLT2 inhibitor, there's the acute drop in GFR or an acute rise in creatinine. That's expected. That's a hemodynamic effect. Again, these patients eventually have better outcomes. With that, I would like to thank everybody for your attention on this lovely evening for this lecture. And I just want to share this, if you want a copy of the slides, you want to use it for your own review, you want to use it for your lectures, feel free to email me. And with that, I will stop sharing and we can go to discussions.
Okay. Wow, Edgar, thank you. Professor Lerma, that was an excellent talk. I think almost everyone is cheering you here. So if we could cheer in person, we'd be applauding. Thank you very much. That was very, very insightful. And I really love the GIFs, sorry, they were awesome. Thank you so much for giving us this talk. I think what I wanted to do is go through the questions in the chat, and I'd like to encourage people, please, to send all of your questions. This is a time to ask. And I think I'm going to start off with the first question, which is, what is the best IV fluid for patients with AKI? And that's actually a really good question. What's the best fluid?
So many years, for many decades, we as internists, right? Remember, as nephrologists, we're internists first before we become nephrologists. We always preach 0.9 normal saline is the best solution for volume repletion, right? And we always cited this because that's what we're taught, right? It's normal saline. And we always chided that the surgeons would say, oh, no, it's LR. We use LR. Until a few decades ago, there's studies wherein they use lactated Ringer solution. It turns out lactated Ringer solution is a balanced solution, which is closer in composition to plasma. So really, your normal saline is abnormal saline, right? In fact, John Kellum, used to be from Pittsburgh, wrote a nice paper in Nature entitled Abnormal Saline. And he discusses here and he shows a picture of how the composition of plasma is closer to normal saline, to lactated ringers as compared to normal saline. So seeing all of this evidence, and there's studies, right? There's so many studies, trial, ideal study, so on and so forth. There's so many studies looking at this, and it tells us actually that LR is probably the most logical solution. I started using LR myself ever since I started seeing these papers. There was the myth that potassium was high in LR, so we should not give it. There's the myth that lactate is high in lactated ringers. That's why there's lactate in it, so we should not be giving it. So I started using this, and actually the amounts of lactate and potassium are actually negligible. So you can actually use it, and that's what I've been using. So if you ask me, what would I use? What would I order? I'd order LR.
Okay, thank you. That's a really, really good question. And yeah, so some like in the critical care data too, like, balanced solutions versus normal saline associated with worse outcomes and hyperchloremic metabolic acidosis. So that's the first question. And a second question, which was, I think this was earlier in your talk, but are ARBs, example, losartan not preferred in patients with CKD for hypertension management? If so, how is it we know that we use losartan and ARBs for kidney disease, but we know it increases creatinine. And I guess their question is, how does that correlate? And I think your last slide kind of answered that about good rises in creatinine versus bad rises in creatinine. I think some problems arise when further to this question, sometimes when people are dehydrated or like they have an acute illness, being on the ARB or the SGLT2 inhibitors, like what do you do? And I think that's a common primary care question. So I'm going to ask that question as a route from this one, when you
Very
have
good.
two reasons.
Sure. So let me ask and remind me if I miss the question, but so I come from the Philippines, and I know there are a lot of people from the Philippines in the audience. We as a culture have been taught that the doctors are like gods, but this was a long time ago. Okay, so when the doctor tells you take this medication, do not ever not take it. You follow that. So even if you get sick, you can't take anything else. You still take your medication, right? uh, it turns out this practice is not actually good. Uh, because remember, I showed the slide about the perfect storm, right? So let's say a patient ate some bad food and now has nausea, vomiting, diarrhea. This is a situation wherein you have to stop your ACE or ARBs or even your SGLT2, because that can cause a perfect storm of leading to acute kidney injury. So what I do in those, I tell my patients, there's something called the sick day rules. When you have an illness or a sickness, you have to stop these medications, like medications that end in ill, like lisinopril, enalapril, so on and so forth, or sartan, right? Losartan, olmesartan, valsartan, so on. You have to stop these medications. You also have to hold up the SGLT2 inhibitors. Now, this is important because what usually happens is that when these medications are stopped, they are never restarted, right? And this is a topic that was actually studied. This was published in JASN a few years ago. And what did they find out? So they look at the patients who had ACE or ARBs discontinued versus those patients with ACE ARBs continued. 10 years later, the patients in whom they discontinued the ACE and ARBs, they had higher major adverse cardiovascular events. While those patients who continued and resumed the ACE or ARBs had lower major adverse cardiovascular events. Very important, okay? So when we do take the patients off those medications, we have to remind ourselves, we eventually have to put them back on it. I think even today, even with as much as we know about the benefits of ACE ARBs on cardiorenal outcomes, there's still some reluctance because of that rise in creatinine that we see when it is initially prescribed. Some patients have hyperkalemia, right? High potassium. But there are now medications that are available in order to offset those side effects. And again, the ultimate goal is to improve cardiovascular outcomes. Don't let the patients die from cardiac disease or from renal disease. Does that answer your question, Lori?
Yeah, I think that's a really good answer. And I think sometimes, what I do is what you say is like if someone's really sick, like they have a flu or, in the times of COVID, if they had a COVID infection, you should tell them to just kind of back off on your, maybe cut down your diuretics or hold your diuretics, hold your ACE inhibitor or your SGLT2, because again, when you're sick, you're not eating, you're not drinking, your appetite's down, you get dry. And so I think that's a common question. That's one or two questions people have asked me from a primary care perspective. So the second question comes from the group, which is, can azotemia and AKI be used interchangeably, or is azotemia only elevation of urea, whilst AKI is both urea and creatinine?
So in nephrology, we like a lot of semantics, right? And I'll tell you, when I teach renal physiology, one of the things I usually teach is when we say reabsorption, it goes to the blood. When you say secretion, it goes to the urine. You have to have that concept. I guess we nephrologists like semantics, make everybody confused, maybe makes us look smart, right? So when we say azotemia, basically it implies an elevation in BUN and creatinine values. That's what azotemia means, right? AKI, wherein you see the elevation in creatinine, usually there is an elevation in BUN as well. Okay, so AKI, although we sometimes think it's synonymous with a elevation in creatinine, it goes unsaid that the BUN usually goes up also. The way I would usually teach this is that usually the creatinine goes in the same direction as the BUN, right? The creatinine improves, BUN also goes down. It is when they cross, when BUN goes up, creatinine goes down, that's when there's some discrepancy, right? So let's say you have a patient whose creatinine is stable and the BUN is going up. You have to think, what else can cause that BUN to go up? It could be bleeding from the gut, right? It could be a meat diet. It could be patient was on tetracycline or corticosteroids. Those can cause the BUN to go up, and the creatinine is the same, right? If the patient has, as I said, GI bleeding, that can cause the BUN to go up because it's urea nitrogen at the end of the day.
Thank you. That's a good question. I think I'm trying to understand this question for cardiorenal syndrome, Lasix BID versus, I think, IV infusion. So infusions versus like bolus dose Lasix.
Yeah, so in practice, when you first see the patients, of course, in the outpatient setting, you want to use PO, right? So I usually would start with a BID dosing in patients wherein they have cardiorenal syndrome. However, in the hospital, I have the option of using IV. I would use the IV first. Now, there's something in nephrology, in critical care nephrology, which we call the furosemide stress test. I'm not sure if you've heard about that, but the furosemide stress test entails that, let's say a patient is in the hospital and you give them a dose of Lasix. I believe the dose is 1 milligram per kilogram per dose in those patients who are not um, sodium naive, or sodium naive, then you give a higher dose, 1.5. No, or the other way around. But anyway, it's 1 to 1.5 grams per kilogram per dose of Lasix. And what it does is that if you give the IV Lasix and they do not respond adequately with good urine output, they are not necessarily going to respond to further diuresis. So that's kind of how I use that dictum. So I would start off with PO in the outpatient setting. In the hospital, I could use IV. If I can see that that's working, I might use an infusion drip, like a furosemide infusion. And sometimes I would use what we call a step care diuretic, wherein you give a loop diuretic and then you add a distal loop diuretic. Of course, this is in the in-house that we're talking about. There's study that was published in the New England Journal of Medicine called ADVOR trial, wherein the patients were given furosemide IV and they had suboptimal response diuretic wise. They gave them a dose of IV acetazolamide, which works on the proximal tubule, and they had more diuresis.
Okay, that's a good point. I think the second question, I hope we answered that question, because I think it was intermediate doses versus infusion, which you answered. And certainly there is a pull to share the urine microscopy app that you talked about. That's one comment, which is great. The other one is, are there no dose adjustment needed for PPIs based on current literature, and why would that be? And when would that be revised? And that's the question, is, I guess, if dose adjusting the PPI would reduce the risk.
So I don't know the answer to that exactly, but let me put it this way. The no dose adjustment is based on the metabolism of proton pump inhibitors, regardless of which brand you're using, or which generic form you're using. There's no need for a PPI dose adjustment based on the kidney function. The suggestion that PPIs were linked to CKD were initially discovered epidemiologically. So now there are smaller studies showing that there's actually a link. But again, the link, there's still a question. Is it all acute interstitial nephritis, or is it more than that? So in my practice, when I see these patients, so when I see a patient with CKD and I notice that they're on a PPI, I would I would ask them target that do you know why you're taking the PPI? Or maybe I would reach out to the primary care provider and ask them, why is the patient on PPI? Can we discontinue that? And I am very careful about this, because I've also read case reports wherein patients had severe peptic ulcer disease, and they were taken off PPIs and they had more problems with that. So it's a matter of weighing balancing the risks and benefits of the medication.
Okay. And I think it's a really good question. What is the permissible rise in creatinine with advancing age in an otherwise healthy person? I love this question.
There's no permissive rise in creatinine. The permissive rise in creatinine I was referring to is, when you use these medications, when you use an SGLT2 or an ACE or ARB, we expect that rise in creatinine, right? That's not unexpected, because that's how the medications work. One of the things and since you mentioned elderly, we have to remember, as we get older, our kidneys go down in function. I always tell this to my patients. In fact, from age 40 onwards, our eGFR goes down by 0.5 to 1 ml per minute per year in the absence of other illnesses. If you have diabetes on top of that, that's uncontrolled. That 0.5 to 1 goes faster. If you have high blood pressure, that's uncontrolled, on top of the diabetes, that makes it even go faster. One of the things I always tell my patients is that we cannot stop your kidneys from going down, because it is part of aging. What we can do, however, is we can slow down the progression. And that's with the use of blood pressure control, diabetes control, proteinuria reduction, avoidance of NSAIDs, so on and so forth.
Okay, thank you. That was a good question. What would you use for or evidence of prolonged topical NSAID use causing elevated creatinine, and any advice to people with chronic kidney disease and chronic arthritis who really need those NSAIDs for pain relief, but the NSAIDs may also cause AKI. What are your thoughts on that?
So there's an editorial written in Clinical Kidney Journal by Dr. Pong Tipam. And this is she's based in the UCLA, I believe, and they wrote about topical anesthetics or topical NSAIDs rather in patients with CKD as a means to sort of curtail that ill effect of NSAIDs. And I think, again, you have to think about it from the fact that eventually it is systemically absorbed, right? So if you use enough of it, then it will be absorbed and it will affect the kidneys, sure. But the thinking here is that the topical is probably less in dose as compared to something that is oral. Now, I am not an NSAID pundit, meaning to say, I would tell the patients, so especially I the other day I just had this, I saw a patient with a GFR of greater than 60, creatinine was 0.8, but she had diabetes and she had hypertension, and she asked me, hey, Dr. Lerma, can I take an NSAID? And I said, my rule in my practice, and again, this is not necessarily evidence-based, this is expert opinion, me being the expert, is that I would tell them, if you need an NSAID, you can take it. But if you have to use it beyond 3 days, then it's a problem. Okay. So I don't tell them absolutely no NSAID. Don't take any NSAID. I would say, if you take it maybe 1 tab BID for 3 days and that helps, go with it. But if you have to take it more than that, longer than that, there has to be somebody looking at what is causing the pain and resolving the pain directly, rather than it being more being given for chronic symptomatic relief. Maybe Lori, maybe the other panel discussants have any opinion on that as well.
Yeah, sorry. So yeah, if anybody else or Suchi or anyone, or I think has any opinion on that.
Yeah, I would agree with Shichian and then one of the nephrologists at Stanford. And that was an excellent talk. Edgar and Lori, thanks for moderating. And I would completely agree that NSAIDs are very effective painkillers, and some of our patients are suffering. And yeah, that's what I prescribe them, is a burst. If they need to do a burst for a short limited time period, I'm usually okay with it. And then I might manipulate their ARBs and diuretics while they're doing that. But I also am very accepting of the topical NSAIDs because that's a very low dose exposure. So yeah, I think we have to balance our patient's quality of life with our laboratory review.
Yeah, thank you. That was a very excellent answer, Suchi. I think there was one question about what was the name of the study about better outcomes with elevated creatinine after diuresis in overloaded patients. He was just asking for that reference. I think I can give that in the chat. Let me see. When would you consider kidney biopsy in AKI? Will you decide based on time-wise or a trend in creatinine?
So one of the indications for doing biopsy in AKI is when you don't have a clear-cut explanation. So you go through your pre-renal, you go through your post-renal, and then all of your workup either suggests glomerular or interstitial diseases, or it does not. Meaning to say, so this happens to me. I just saw a patient the other week wherein, we ruled out everything. It's not pre-renal, it's not post-renal. There's some blood cells in the urine. That makes you think glomerular, so you might need to do a biopsy, especially if the kidney dysfunction is either persistent or not improving. You have to find out what's going on. You cannot just sit on it sometimes. So all that would drive me to say, maybe we need to do a kidney biopsy.
Okay. And I think we can, that's a really good question, really good answer. And I think sometimes, especially in our population, which has a lot of lupus, a lot of the signs, they may not have an elevated creatinine, right? And that's where that urine dipstick is super important. What they'll have is proteinuria, hematuria, and positive leukocytes. And if you see that as part of your workup, like you just do a dipstick in your office and someone's blood pressure is elevated, they have that nephrotic syndrome, that is a reason to do, talk to us and call us, because you want to, that person, you should try and get them seen by a nephrologist sooner rather than later. And I think there is another question, which is, is serum creatinine the best biomarker to diagnose CKD? And Edgar, if you want to take that, and I'll also add some to that as well. I know that's kind of a tough question. Yeah.
So the long and short answer is no. Right. No, but the long answer is really so creatinine is a biomarker that tells us that the patient has kidney dysfunction, right? That there's already damage to the kidneys. Unfortunately, the creatinine, by the time you see that it is up, there's already significant damage that has happened. So there are studies wherein they're trying to determine which is the biomarker that fits, that would be elevated before creatinine gets up, right? We've seen studies on NGAL. We've seen studies on KIM1, which is the kidney injury molecule 1. There's also something called NephroCheck, which is TIMP 7 IGFB, something like that. But it's NephroCheck, which is a urine biomarker. And really, what it is that I think it's a combination of things. You combine the clinical picture and with the biomarker, and that makes you arrive at a situation where you could say, okay, this patient with all of these risk factors, with this biomarker being up, is most likely going to go to AKI in the next 3 to 4 days, or this patient will likely require dialysis in the next 3 to 4 days. So at that point, the hope that research is trying to achieve is that we are going to be able to intervene earlier before waiting for the creatinine to go up.
Okay. What is the role of cystatin C?
So cystatin C is not yet widely available, but there are studies that show that the use of cystatin C as a biomarker in addition to GFR actually increases the accuracy of the GFR equation. So that is the role of cystatin C. In the US, there are now laboratories that allow you to obtain cystatin C. I think initially we were not ordering this because number one, it's very expensive to order it. Number two, it's not widely available. Number three, in the past, the studies were not really solid. Maybe not solid is not the word, but in the past there is some very little evidence that support it. But nowadays, I think from the lab of Dr. Leslie Inker and Dr. Andy Levy, I think they've seen, and these are the people who did the GFR studies, the MDRD, the CKD-EPI. In their lab, they are demonstrating that cystatin C actually increases the accuracy of being able to measure that GFR.
Okay, and I think this last question I was trying to answer online, but I think I probably answer for the benefit of the talk is, if the patient isn't producing urine due to renal failure, how often can you challenge the kidneys with Lasix? Yeah.
So this is where, the patient's not making urine, you need the patient to diurese. This is where you give your furosemide stress test. So let's say, a patient is, say 70 kilograms, I would say give, say 80 milligrams IV of Lasix. If they respond with significant urine output, that means there's tubular integrity. That means you can still use diuretics to make them make urine. On the other hand, if they fail the furosemide stress test, there's a very high likelihood that they will require some form of renal replacement therapy, whether hemodialysis or CRRT in the next day or so.
That's a good question. And I think, some of the adage, well, we were taught in like medical school, it just converts one form of renal failure to another, an oliguric to non-oliguric. And nephrologists are always happy when they see urine. So, and in that way, the other question, which I thought was a really good question, is would you initiate an ACE or an ARB in CKD stage 4, 5 kidney disease? And I'm going to open that out to the group. And I think that's a really good question, and it's a really good common question being asked.
Personally, I would start the patient on ACE or an ARB, and mainly because they have cardiovascular benefits. Early on, stage 3, you start them because of cardio-renal benefits. When patient has, let's say a patient's already on dialysis, there's no more renal benefit, right? But there's still cardiac benefit. So my attitude is I still use it.
Yeah. And I think, to add to that question, I agree with that. I tend to use ACE inhibitors, and, the big Stop ACE trial showed that, when we stopped ACE inhibitors at advanced kidney disease, they died from cardiovascular complications. And I think a big learning point from that, and we need to remember that our CKD patients are cardiac patients. The mortality, the reason why patients with CKD die is cardiovascular disease. So we need to remember that in our patients. And I think the warning would be looking out for more hyperkalemia. And, you may get a little bump in the creatinine and progression. But, I think long-term, I agree with Dr. Lerma, definitely on this one. The cardiovascular risk is too high amongst our, especially our advanced CKD patients. Okay, so I have 2 last questions because I'm sure everybody is reaching exhaustion. But I really love the questions from this. In cases of like an AKI consult, does not all Muddy Brown casts equal to ATN? I guess their question is, can you see Muddy Brown or classic granular cast in other forms of renal disease? He asks RPGN, anti-GBM disease.
I think the theoretical answer is yes. Because some of these patients can have glomerular disease and ATN as well, right? So you might see that finding as well. One of the things, I'd say be careful about this. Like in one of the hospitals where I work at, we are not able to do urine microscopy. So we are reliant on the lab to tell us what the urine sediment findings are. And this common scenario is this. So patient, I do a consult, 7 a.m. Here, I need a urinalysis. Nurse collects the urine at 7:30 a.m., which is pretty efficient, 7:30 a.m., right? 30 minutes from the consult. And then that urine sits there for like 6-7 hours. If you had an RBC cast there, that's gone. If you had a muddy brown granular cast there, that's gone. So when the lab reads it, there's no mention of cast, there's no RBC cast, there's no granular cast, there's no nothing. So I usually use that example to say that, you kind of have to practice you have to adapt to the setting of your practice. If you're able to do all of these tests, well, then good. But sometimes the situation that you're in is limited and you're unable to see those findings. You still have to use your other clinical acumen in order to arrive at the diagnosis. So you still make the history and the physical fit in what you're thinking.
Okay, thanks. And I guess there was last question, which I'll quickly ask, which is about the time frame between PPI and nephrotoxicity. And, if the cause is unknown. I mean, just kind of knowing that like there's causation and association. So we know that like chronic kidney disease, or at least there's an association with chronic kidney disease with PPI use, meaning that in these big studies looking at populations, they found that those people who are taking PPIs were more likely to develop kidney disease. But does that equate to causation? We're not sure,
Yep.
So we know that PPIs and any drug really can cause interstitial nephritis, because it's kind of like this inherent reaction to it. You have different types of interstitial nephritis. So you have the classic eosinophilic one we learned which is an allergic reaction, which would happen like usually 7 to 10 days after the drug is initiated because you need an inflammatory response. Or which is that PPI causing AKI. In that setting, you'd have a temporal relationship between it. But certainly for many cases of CKD, it's just an association. So we will never know the temporal event. But in the event that this is acute interstitial nephritis from the PPI, it would be about 7 to 10 days after initiation. That's when you'd see the rise in creatinine. And I hope that answers that question. But thank you guys. I thought that was a really good discussion, kind of question and answers. You can always tell that someone did a really great presentation because there were like a ton of questions. And I'd like to really take this opportunity to thank Professor Lerma and especially Professor Lerma, because I love that talk. I'm very excited about it. And I learned a lot, even as a nephrologist. So this was an amazing talk. Thank you so much for your time and efforts. Thank you so much to the Caribbean College of Family Physicians for hosting us. I'm going to spend probably about another 10 or so minutes kind of having a discussion about our thoughts. I'm going to invite Professor Reid to kind of give a sum up on any other kind of discussion points from this talk. Prof. Reid.
Hi, thanks, Lori. Colleagues, hopefully you're hearing me well. I'm having a bit of an internet challenge here. So I was quite impressed with the chronic care model framework that was shared, because we recognize that chronic kidney disease is really just literally that, a chronic disease. And we recognize that the only way you're going to have reasonable success is if it is that one takes a holistic approach, and the chronic care model does facilitate that kind of an approach to our patients. Just wanted to ask one question here, Dr. Lerma, and this is your view of point of care creatinine testing in the office. What's your view in terms of their sensitivity and specificity for monitoring kidney functions in the general population?
So I think I draw back to my first slide, wherein, again, when we draw a serum creatinine in a patient, we first and foremost have to ask ourselves, is this a true or valid creatinine elevation or not? And once that is established, then your next question is this an acute or a chronic rise in creatinine? And in a patient with a previous lab test, you have something to go back at. But if you don't, you only have the one number in front of you. At that point, you just have to use the other sort of weapons in your armamentarium that will allow you to, how to navigate this, how to approach this. Again, just going to your pre-renal, post-renal, or renal. So that's kind of how I would view creatinine. But right now, we don't have anything else besides creatinine. Hopefully, for many years, for many decades, we've been hoping that the NGAL test would be it, that and NephroCheck would be it, but we don't have it right now. So creatinine is our best marker. In physiology, we teach it because it's only 7 to 10% tubular secretion of creatinine, right? And it's not reabsorbed. So again, I go back to the to the older studies in supporting it.
Sure. And the other question I would just ask you to comment on, in one of your slides, you mentioned when you were looking at the benefits versus risk for early versus You mentioned one intervention, which is not available here yet, and that is preemptive transplantation. And the extent to which, has there been a cost-effective comparison for a low-resource country instituting a program like preemptive transplantation rather than investing in renal replacement, whether it be peritoneal dialysis or hemodialysis?
So I can only cite the studies in the US that I'm aware of, wherein preemptive transplantation is available and it has shown benefits. I'm not sure, maybe Lori or Shuchi would be more available about the, more knowledgeable about the studies in low to middle income countries on that aspect.
Yeah. Yeah. So I'm not so of the Caribbean countries, Trinidad has the best data for kidney transplantation, not necessarily preemptive transplantation. I'm not sure we have that data yet, to be honest, to say like the cost effectiveness. I think because there's so much variability in how dialysis is paid for and in Caribbean countries. You know, and even when you talk about health economics, it's not only when you think about people who have end-stage kidney disease in low-income countries, they tend to be younger than those in high-income countries. And so the years lost by dialysis, because transplantation helps not only improve quantity of life, but quality of life. Remember that renal replacement in terms of hemodialysis or dialysis, which is commonly available, may also reduce quality of life in people who are at a low workforce. So to answer your question simply, no, we don't have that data from low income countries, but also to say that low and middle income countries, also to say that bearing in mind that end-stage renal disease happens often in younger age groups. I can definitely say that from the African data and also from data from the Latin American countries. And so, you know, we also have to add that to the equation. In terms of point of care testing for creatinine, Suchi raised some really good points, which is there's a lot of variability in creatinine point of care testing for creatinine. I know that, you know, they do use some point of care testing in Latin America and kind of algorithmic approaches using primary care and nephrologists using point of care testing in like the clinics. So in a community center to identify those patients with community acquired AKI. And they specifically had like an algorithm. So does this person have risk factors for AKI? And therefore I would reflex to do this creatinine. So I'd be cautious in interpreting it. I think it can be useful in appropriate settings, right? So certainly in like high risk groups, like you're in the middle of, I'm going to use Jamaica. I'm going to say Jamaica, the middle of Woy, which is like a rural area, right? Where, you know, you may have, I mean, I was in Sav, like you could be in the middle of Sav Lamar and you're the only primary care doctor, you're in the clinic, and you see somebody that comes in who, you know, you think may have lepto, you know, who had vomiting, diarrhea. That person has a high risk for AKI. And you do this point of care creatinine, it may help you triage. And I see where that would be helpful, right? They may say, okay, maybe this person has a high creatinine, but he has a history of vomiting. He has jaundice, you know, he has the perfect setup for AKI. I do this creatinine, it's high. I'm going to send him to the hospital, give him fluids. And I think it would triage management. So I think that's where it would be useful in our setting. But we kind of have to acknowledge its limitations, which is creatinine is not the best model for, not the best marker. We're not like the cardiologists who have cool markers for impairment of function, and also just point of care testing. There's a lot of variability. So I think it's useful for risk stratification, but I would have to prove that, wouldn't I, Professor Reid? But yeah.
And to Lori's point, I remember one of the studies I saw and read in one of the posters and from the World Congress of Nephrology maybe a couple or 3 years ago is the use of salivary urea nitrogen. And I was reading this poster and I said, oh my God, I guess there are places where you can't even really get creatinine. What do you do? And I guess whenever you have nothing else to use, whatever you have is available, you make the most of it. I think that's how I would sort of treat that.
Sure. All right, colleagues, I think, as we said, those are my few comments as we come up on the hour mark. So Laurie, all over to you.
Oh, wow. Thank you, guys. I kind of wanted to summarize the key discussion points so that, like, I know we've gotten a lot of information and I kind of wanted to make sure we kind of consolidate. Please answer the post test because we want suggestions as to what you want to hear. This is a two-way street. I mean, Dr. Lerma, again, thank you so much. That presentation was awesome. And I love the GIFs, and I love that nephritic picture. That was the Burger King. That was amazing. And if I remember anything from that presentation, I remember that slide. But I think kind of what we wanted, the whole thought behind this presentation is one, recognizing that not all elevations in creatinine are bad. Yes, a nephrologist is saying that and being recording saying that. I think we need to recognize, at least from, and Dr. Lerma can correct me if I'm wrong, that, is this a true rise in creatinine? And if it is a true rise in creatinine, is this pre-renal or post-renal? Rule those out first, then go to intrinsic renal. If we think intrinsic renal, think about parts of the kidney, so glomerulus, interstitium, tubule. Where could it be along that line? Look at urine. Is there protein? Is there blood? Are there hyaline casts if we're able to spin the urine? Because, I mean, some offices have that little centrifuge, spin the urine right away. Is there a cast? Yeah. And do your other investigations, ultrasound, full blood count, renal panel. Remember those nephrotoxic drugs, stop them. Treat the underlying cause. And always consider calling your neighborhood nephrologist, especially when you think intrinsic renal and when you're not sure. And I think those are my, big take-home points. Dr. Lerma, feel free to add.
I think you captured everything.
Yeah. And I'm hoping to kind of finish off this talk by thanking everyone that was involved. We do have a subcommittee amongst the International Society of Nephrology, the North American and Caribbean board, that was crucial in organizing and helping this process moving forward. I'm going to take this opportunity to thank every one of them. I am thankful, grateful, honored to have Dr. Lerma do this talk. It was great. Suchi Anand, Sabine, Michelle, everyone, thank you so much for joining. And also want to thank the amazing Caribbean College for Family Physicians who were excellent hosts. They made a lot of the advertisements possible. Big thanks to Lynn, who has been calling me to remind me to do things. And I often forget still, but thank you so much. This was an amazing webinar. And we thank you so much for organizing this and being able to do this in a big social platform. The last and most important people in this group are the people who came out and listened to us. I'm so happy that at one point I saw 480 people. That is amazing. So thank you so much for your attention, for your questions, and for your time, because this was an amazing talk. And thank you so much for joining them. I love the questions. I love the participation. I'm hoping, and we are hoping, to serve you better by doing another talk in hopefully another 3 months. And, please, part of the link was, what did you want to hear and how can we improve? How can we make this better? So please fill out the forms or let me know. It's going straight to my email. And I'm going to put my email in the chat. So please send me emails or if possible, if you want any questions, and we're just resending the link as well. And I'd like to, again, thank everybody for attending this great webinar. And any closing remarks from Lynn and the group?
No, I
Or
think
Prof.
you
Reid?
did pretty well, Lori. And
Okay.
on behalf of the college, I would just want to thank you and their panel, Dr. Lerma, for this talk. We look forward to future talks together, future collaborations, and as we strive to do the reason for being here, which is to improve the lives of our patients.
Hey, thank you.
All right. Thank you all so very much. Stay safe. Those in Jamaica, stay dry. And we'll see you at the next talk. Have a good evening.
Great.
Bye-bye.
Oh, wow. Thank you so much, Edgar. This was amazing. Thank you.
Thank you. Thank you.